Hello viewers, my name is Andrew Dean. I'm the Vice President of Research and Innovation at Lakehead University, inviting you to another edition of Research Matters. Today we'll meet Dr. Katherine Kortes-Miller, an Associate Professor in the School of Social Work at Lakehead University. Dr. Kortes-Miller is also the Director of the Center for Education and Research on Aging and Health, or as we call it, CERAH, and holds the Lakehead University Research Chair on Aging and End of Life. Welcome, Katherine. Really glad to have you here. Could you maybe just tell us a little bit about your professional journey coming to Lakehead and in this role, and then maybe a little about your research activities?
I'd love that. Thank you for the invitation, Andy. So my clinical background is obviously in social work, hence I'm in the School of Social Work. And I worked for many years as a social worker at St. Joseph's Care Group on the hospice unit. And there I had the privilege of working with an interdisciplinary team and became very passionate about improving end-of-life care for Canadians, specifically, of course, here in Thunder Bay and the region of Northwestern Ontario. And then I had the opportunity to work with Dr. Mary Lou Kelly, who is a former director of the Center for Education and Research on Aging and Health and a professor in the School of Social Work before she retired. And she was quite interested in building capacity in palliative care education. And so she brought me on board as a sessional lecturer for the School of Social Work, but in gerontology as well. And so I was able to use my clinical skills to be able to think about how do we prepare healthcare providers to take care of people as they're nearing the end of their life, to promote that idea of quality of life until the end of life.
Great. And so your research is mainly in that area right now?
It is. And so being an applied qualitative researcher has allowed me to think about some of the questions and some of the opportunities that my clinical work would see and use research in a way to best serve our region. And so that kind of will lead me to, I'm hoping, what we'll talk about around medical assistance in dying.
Okay. So you're the current director of CERAH, which is wonderful. It's, viewers, it's one of our larger research centers. And I think one of the things that kind of makes it stand out a little bit from some of the other research centers, besides how long it's been around, is that it's not just about research. It's also about education and knowledge sharing. Can you tell us a little bit about the center and your role as the director?
Yeah, absolutely. It is an privilege and a pleasure most days to be the director of the center. We have a great group of very talented and well-educated knowledge brokers and division leads at our center. Our center has 4 divisions. The one that is closely linked to my research is palliative care. We have Indigenous Peoples Health and Aging, which is led by Holly Prince. We have Geriatric Mental Health, which Dr. Elaine Wiersma leads. And we also have a division which is up and coming on aging in place. And so our center, as you have said, not only do we have a number of research grants that are flowed through our center, but we have a number of commitments to building capacity and educating healthcare providers across our region. So we do that as part of the palliative care division. We do that as part of the Indigenous Peoples Health and Aging, and of course with geriatric mental health.
And can you tell me a little bit about the research chair that you have? I know you got that last year. Excited to have given you that.
Yeah, thank you. And I was really excited to receive that because it provides me with the opportunity to take some of the work that I'm doing and really focus in on Northwestern Ontario and what is happening here as regards to end of life, but specifically medical assistance in dying, because it was the work that was occurring here in Northwestern Ontario that first got me really interested in MAiD when it was first legalized. And so with this chair, I am hoping to learn sort of what is unique in terms of what's going on in Northwestern Ontario in terms of the delivery of medical assistance in dying. So both from the recipients, so people who are accessing MAiD, and their family members and friends who might support them, and also healthcare providers.
I noticed that one of the pillars is aging in place, and I think for a region such as Northwestern Ontario, where distances are great and people, may not have the same family structures and like this must be a really important part. And how do you make sure that funding is in place, alignments of healthcare is in place, but also how that's done in a respectful manner?
Yeah, Andy, you're right on point. I think we are seeing more people in Canada really prioritize aging in place. I know my own parents are aging in place here in Thunder Bay, and it's a priority for them to stay in their home as long as possible. We're hearing that from many people in Thunder Bay. And so they're looking for that community, that capacity, that thinking of how can they support each other, but also to be independent living. And so this idea of aging in place within our center, it allows us to connect with some great community groups, such as Age Friendly Thunder Bay, Age Big, and also Oasis, which is a new group that's happening in partnership with Roots, one of the fabulous organizations that we have here in Thunder Bay.
Can you tell us a little bit more about that?
Yeah, Oasis is actually based on a research project that originated at Queen's University. And it looks at building supportive retirement kind of natural communities with older adults. And so at Roots to Harvest, they have worked towards supporting two different community groups, one at the Bayview Towers and one in Castle Green. And it sort of pays attention to the natural growing relationships that people have and thinks about how can we support them better. So how can we make sure people are focused on exercising, thinking about nutrition, and of course their leisure activities and how we connect and naturally take care of one another.
And I think it's one of the things we hear more and more, and thankfully we are, is quality of life for people who are aging, people who are closer to death. And I think it's just hasn't been part of the conversation for so long. And, this sounds like your research, but also the education part is really very much focused on that.
Yeah, and at CERAH, we have been doing education with healthcare providers for over 20 years now. And so I'm hopeful, and what I've seen is that the education is improving for healthcare providers. I remember way back when I first started at Lakehead and people didn't take courses on end of life or grief and loss. And now most students that come to Lakehead have exposure to that. And that really helps to support them in the work that they end up doing as healthcare providers, but also as citizens of our community.
So that's an interesting point. So, many of our students are young, 18 to 24. That seems like a long ways away, end of life. And I think sometimes programs like gerontology and these ones actually maybe don't get quite the uptake or interest from students. They're much more interested, say, with diseases of today or something like this. Are you finding that's changing at all? Or?
I hope so, because I think students should be hearing, and will hear probably multitude of times throughout their education, that our demographics are changing, that our population is getting older, and they are living longer and arguably better than they ever have before. But that doesn't mean, regardless of where the future healthcare providers of tomorrow, which we educate well at Lakehead University, they're going to encounter dying and death regardless of the setting that they're working in. And so it makes sense that we build that capacity earlier on. And so I think by normalizing and socializing dying, death, loss, and grief, that can really help us to begin that foundation and that knowledge and potentially that interest in the future healthcare providers of tomorrow to be able to provide that kind of care out in the community.
I do like how you use the word normalizing and to bring that into our way of thinking. I mean, people do die, people do age.
Yes.
These are not things we just ignore or shouldn't ignore as a society.
No. And I like to align with the very famed philosopher John Cleese, who says life is a terminal illness which is sexually transmitted. Sorry, I couldn't resist.
Okay, that's a wonderful break here. All right, well, thank you very much for introducing our research to your research. We're going to take a short break and be right back with our discussions with Dr. Kortes-Miller. Thank you. So before the break, we were introduced to Dr. Katherine Kortes-Miller and some of her research interests. In this segment, we're going to learn more about one of her ongoing research projects on medical assistance in dying, or commonly known as MAiD. So, Kathy, you're in the middle of a 5-year research project looking at the experience of MAiD across Canada. Can you tell us a bit more about that?
Yeah, I would love to. So I'm very lucky to be part of a team that received funding from the Social Sciences and Humanities Research Council, a 5-year Insight grant. And it expanded on work that we had done previously that we focused on the province of Ontario. And so we have 3 phases within our 5-year grant. The first one is ongoing, and we are speaking with people across Canada who are accessing MAiD. And so we're interested in hearing about their experiences, what motivates them to have conversations and to engage within the healthcare system to be able to access MAiD, what are some of their challenges in terms of potential systemic barriers, and how they're having conversations with those people closest to them. So not solely healthcare providers, but those people who love and care for them as well. And so trying to gather that experience. And we're doing that over a number of years because, as probably you're aware, Andy, there had been some discussion about extending the legislation of medical assistance in dying to include mental health as the primary diagnosis. And so we were thinking of paying really close attention to that. And we had a number of people who were hoping that that would move through, participate in our study. So that has been an interesting piece as a phase. The second phase is that we're doing focus groups and interviews across the country, focused at more of the provincial experiences around accessing MAiD. And we're speaking with those people who've accompanied someone who used MAiD at the end of their life. And so it could be friends and family members. And that has been interesting to do in both the focus groups and the interviews and see how different provinces are providing what we're now calling MAiD care. And so thinking about the support that occurs before MAiD is accessed, the actual procedure of MAiD, and then the support afterwards for people when they're grieving. And the third phase is we're, of course, interested in healthcare providers' experiences. And some work that we had done early on in 2016 when it was legalized, we focused primarily on physicians because that at the time was the discipline of healthcare that was most responsible. But we're now seeing that there are interdisciplinary healthcare providers who are involved in the MAiD process in terms of the support, in terms of accessing MAiD. And so we're hoping to get a better understanding around that, thinking about things like conscientious objection, thinking about ideas around where people see track 1 and track 2. So when death is reasonably foreseeable in track 1 and where death is not reasonably foreseeable in track 2. So it's a bit of it feels to me as a researcher, a big project with a number of different pieces. But if I was to highlight 2 of my favorite components of the research at this point, is that we're using digital stories as a way to connect and share information around medical assistance in dying and capture people's experiences. And so we have completed at this point 14 different digital stories on MAiD, and we've shared those through our podcast, which would be my second favorite piece of the research project at this point.
It's very, very novel. Yeah, it's interesting. So, I mean, in Canada, we have federal government regulations, but a lot of healthcare is provincially driven. Do we see a lot of variance in Canada with different legislations?
We do, because in 2016, the federal government said, okay, the Supreme Court of Canada has decided that medical assistance in dying is legal, but how we deliver healthcare is provincially based. And so the funding was given to the provinces to do things differently. One of the shout outs that I think is important that we pay attention to here in the province of Ontario is that every death that used MAiD is reviewed by the coroner's office in our province. And so often people have fears around whether or not the legislation is being followed correctly. And here we have in Ontario instituted a procedure where those deaths are reviewed. So we do know a fair bit about how people are accessing MAiD, how they are assessed, and how the provision occurs.
And do you have the opportunity from your research and being really, really immersed in this area to perhaps add to those legislation debates? Or?
Well, I'm hoping we get to be part of that conversation. And when you brought up the provincial piece, I think it's really important to note that we're learning from different provinces. So, for example, some of the Western provinces, including Manitoba and Saskatchewan, often MAiD is provided by an interdisciplinary team. So, of course, you have access to a physician who is responsible for the delivering of the medications that are part of the MAiD procedure, but there's also a nurse, and often in those provinces, there's also a social worker who is there to support the family and friends of the person who is choosing to use MAiD at the end of their life.
In one sense, it must be very exciting to be involved in research that you're obviously passionate about, but also extremely current and evolving, as we go along, right?
And I would say it's that evolution that inspired us to really start the podcast, which is part of our knowledge translation for the overarching project. So I alluded earlier, we had some funding previously from the Social Sciences and Humanities Research Council, an Insight Development Grant in Ontario. And at the conclusion of that, we held what we called a research symposium. But because it was COVID, we did it online and we could open it up to people. And so we had 400 people register for this research symposium. 250 came to the evening presentations. And we realized that people had a lot of questions about medical assistance in dying, and that there was a lot of misinformation happening out there. And so, of course, in that evening, we frantically fielded as many questions that we could have from the general public, but also healthcare providers and researchers and people interested in accessing MAiD themselves. So we figured with our podcast, we would be able to take some of the learnings that we were experiencing because of the national-based research that we were doing, but also to figure out who were the key players or who are the key players in the MAiD legislation and interview them, and so that we can provide timely information as the legislation evolves throughout Canada, and to pay attention to some of those important events.
I know you really make it a point to have these public engagements and to listen. What are the kind of things you hear from the public? I mean, that's a big question, because there must be so many different things when you have these, because it's such a such a personal and emotional area.
It is, and I think the public engagement is really important, and our center, CERAH, supports some of the education that we do with public groups, but also we partner, for example, with Hospice Northwest, and we had an event last year in the winter months, and we had over 100 members of our community come, and they asked really important questions. And I would say, Andy, that one of the questions I hear most frequently right now is people are concerned and scared about getting dementia, as we recognize that more people are developing dementia as they move towards the later years of their life. And so people want to know if advanced requests are going to be something that's available to them. And right now in Canada, advanced requests are available in Quebec, but no other provinces at this time.
Oh. Well, we're going to take a quick trip break here. Thanks, Kathy. There's so much here to think about and digest, but this has been great for this segment, and thank you very much.
Thank you.
Welcome back, viewers. Okay, we're joined by Dr. Kathy Kortes-Miller. Sorry, too fast. Welcome back, viewers. Today we're joined by Dr. Kathy Kortes-Miller, whose research focuses on palliative care and medical assistance in dying. And earlier we mentioned how you were the director of the Center of CERAH. Can you tell us some of the other research initiatives that are being worked on by CERAH or by the researchers at CERAH?
Yeah, one of our divisions, Indigenous Peoples Health and Aging, has been engaging actively across Canada, but specifically in northern communities, to build capacity around a palliative approach to care, and has developed different curriculums and worked within curriculums that are present nationally as well, to be able to indigenize those curriculums, to be able to think about how we talk about dying, death, loss, and grief in a way that fits with Indigenous communities. And so we have a number of initiatives within that particular division that are being actively paid attention to from a national level, and that we're working alongside some researchers at McMaster University to think about how we're evaluating those, paying very much attention to Indigenous research methodologies as part of that, having had the privilege to be invited into Indigenous communities to work alongside them. We also have some great research that Dr. Elaine Wiersma leads, focused on dementia care, working very much with communities. We have the Northwest Dementia Working Group as part of our center that has done some great work and connections into the community in terms of the Dementia Cafe that happens. additional research out of the palliative care piece. We are partnering with Dr. Kelly Stadjahar out of the University of Victoria, who does some work around thinking about how do people who are structurally and vulnerably housed, people who might be living rough in our communities, how do they access a palliative approach to care? How do they receive care that allows them to age in place through the end of their lives? And so we're going to be starting up some of that work here in the new year.
Very interested in the Indigenous palliative care work, and I think it also many cultures, people death and dying and palliative care probably is very different from one culture and one society to the next. Is this something that you've been able to learn as well for as researchers? It's not just us providing knowledge and expertise, right?
It's absolutely not us pushing out knowledge. I would say it's one of the things that I have learned a lot as a human being in terms of, you picked up earlier in our conversation about the idea of normalizing and socializing dying, death, loss, and grief. And I think in Western society, we have tended to turn over our dying into our healthcare system. What I hear and appreciate from some of the opportunities I've had to work with Indigenous communities is that they're very much focused on the community and taking care of each other in a way that I would say those of us working in more urbanized settings can really learn from. And so seeing that dying and death is not something that occurs in isolation, but is rather a social process. And I have learned that very well from Indigenous communities.
Oh, tell us a little bit more about podcasts. I mean, podcasts are becoming much more a common way of doing knowledge mobilization, but how does yours work, and what do you think the uptake is?
Yeah, so our podcast is called Disrupting Death. It's similar, named after our shirt grant. And we offer episodes once a month. We started with Sandra Martin, who is the author of A Good Death, which is kind of the seminal book that explains medical assistance in dying historically in Canada. So we have different guests every month, ranging from politicians. We've had Senator Wallen on our podcast. We've had healthcare providers. So Dr. Stephanie Green from BC, who perhaps is one of the most famous Canadian MAiD providers. We had Cynthia Clark from Alberta speak about talking with kids about medical assistance in dying. And that was probably our most popular episode because I think people are really looking closely to have those conversations with the important young people in their lives. Most recently, we had Dr. Dirk Heyer, who is the Ontario Chief Coroner, as a guest. We've talked about things with physicians. I'm thinking of Dr. Joanthe, forced transfers, which in our community in Thunder Bay is a thing. So when there are different institutions, because of their religious beliefs, despite being publicly funded, they have the opportunity to conscientiously object to have MAiD on their sites. And so people who may want to access MAiD that are receiving care in those institutions need to move somewhere else. They need to move home, or in the case of Thunder Bay, they move to the Thunder Bay Regional Health Sciences Center. So this has been stopped in Quebec, another one of their forward-thinking pieces. But out in BC right now, there's a court case happening trying to stop forced transfers. So that was one of the things that was happening at the time that our podcast attempts to address. We also speak to photographers and artists. We had a playwright on who had written a play about MAiD, and it was the kind of theater that involves people's comments from the audience as the play is being performed. And so we had the opportunity to learn a little bit about that as well. And we also have housed the digital stories that our research project has done through the podcast. And all of our participants wanted to be part of the podcast and talk about what creating the digital story was like and why people should watch their digital stories as well.
You mentioned about children, and I think one of the things that's difficult about MAiD, or maybe not difficult is the right word, but just how people need to kind of understand or cope with it is how you talk to family members and how you try to make them understand a particular decision, and that's a very different conversation to someone in their 70s as opposed to someone in their teens or younger. And So is one of the aims is actually to probably give people maybe some ideas of how to have those conversations and understand?
I hope that is part of one of the outcomes of our podcast, is when people have the conversations, that people will pick up on that and engage in those conversations themselves. Having been involved in MAiD research since the onset of 2016, one of the things that I've noticed is that the stigma around MAiD is decreasing. When we first did our Insight Development Grant, we were speaking with people who'd never spoken to somebody else who'd accompanied someone who used MAiD. That now doesn't really happen anymore. Not entirely, because of course we have some remote communities where MAiD may not be as commonly practiced, but generally people have those connections. And so they're talking about their experiences, they're sharing some of the meaningful moments that may have occurred at the end of life or when they were preparing to be able to access MAiD. And I think those stories are really important for educating people. And also, as you said, from the practical piece of being able to talk to the next generation about end of life and how to use opportunities to make that as meaningful as possible.
Well, this kind of work doesn't happen without some kind of funding. Who are the funders that are being involved in the research of your research, but also on CERAH?
Yeah, so thank you. So the research that I was talking about I'm very grateful for the funding from the Social Sciences and Humanities Research Council. I'm grateful to Lakehead University for the research chair. We also have funding from our center through Ontario Health. We've received federal healthcare funding as well for some of the education that we are doing. We have some funding through different partners, including St. Joseph's Care Group, that support our work. And so, yeah, we're really lucky with the relationships and our community connections to be able to do the work that we do at Lakehead University in general, but specifically our center.
One of the things I've often talked about is how I'm really pleased with how the research at Lakehead has an impact. I think this is exactly the kind of research that certainly has an impact on day-to-day lives, but also on policy, legislations, and issues going forward. Yeah. Okay, research has a role to play in all aspects of our lives. In today's episode, we learned how important it is to examine the experience of those most intimately affected by MAiD legislation to ensure that these laws are fulfilling their original purpose and providing the best health care for those who need it. Thank you very much for joining us with Research Matters here. And thank you, Katherine, for being with us. And I'm Andrew Dean, Vice President of Research and Innovation, wishing you the very best.